All right, folks, we're going to get started, so we'll be on time. We're going to get started, so we'll be on time, and we can all get home at a reasonable time. Thanks for coming. We have a great symposium, hopefully, on tricuspid valve tonight with a lot of good talks. Tricuspid valve, as you know, is being quoted as being the forgotten valve because honestly we haven't had a good therapy for it. In the guidelines, the only therapy that's written as a class 2 is really diuretics. But what we're finding out now with transcatheter techniques being developed is that tricuspid valve by itself and tricuspid regurgitation specifically can cause long-term morbidity and mortality, and maybe, and we don't know yet for sure, and trials are ongoing, but maybe treating it sooner rather than later might be beneficial for the patients. It's a very dynamic field, and hopefully we can give some insight to what's going on in this area right now. So with that, we have a great panel of speakers. I want to start with introducing Eugene So from Carient. Eugene is one of the newer members of Carient, perhaps not the newest, but one of the newer ones. Eugene came to us from Walter Reed after a very illustrious career in the military. He's done multiple rounds of duty, served our country in both Afghanistan and Iraq, and then came back and started the TAVR program at Walter Reed. So we're very lucky to have him retire and join us. And Eugene is going to talk about the natural history of tricuspid regurgitation.
Hey Shawn, thanks for having me. Pleasure to be here tonight. Good to see so many familiar faces. I wish I could say I was talking about something near and dear to my heart, but let's be honest, there's not a lot of people in the room who tricuspid valve is really near and dear to our heart, but that's part of the reason why we're here, right? To learn more about this really forgotten valve. Hopefully raise all of our awareness of how significant this is. Anyone who reads an echo knows how common tricuspid regurgitation is. And this is illustrated in the Framingham study, where about 85% of patients had some degree of tricuspid regurgitation. And I think that mirrors our practice. Anyone who reads an echo, it's rare that we don't see some degree of tricuspid regurgitation. It's the number of people who have moderate to severe tricuspid regurgitation is really pretty staggering. 1.6 million people in the United States are estimated to have moderate to severe tricuspid regurgitation. And this incidence only appears to be rising as the prevalence of atrial fibrillation and intracardiac devices and other potential contributing etiologies are also rising. So it's definitely a problem that we need to find a better solution for. As many of you know, it's often just a routine finding on echocardiography, and we're often as clinical cardiologists left wondering what exactly to do about it. And then, of course, I hopefully will illustrate to you in the course of the next 10 minutes that significant TR is important for us to be aware of because it's an independent predictor of mortality. It's something that I think a lot of us aren't necessarily attuned to in daily practice. So just a quick slide about the anatomy of the tricuspid valve. It is the largest and most apically positioned of our valves. The effective orifice area of the tricuspid valve is in the range of 7 to 9 centimeters squared, so much larger than the other 3 valves. One of my favorite pimp questions when I used to round in the military with fellas is, how many leaflets does the tricuspid valve have? 3. And you'd be shocked. You'd be shocked how many people that stumps. You would actually be shocked. But of course, the tricuspid valve does have 3 leaflets, and there's some variability there. Sometimes there are 4, sometimes there's 2. But typically, the tricuspid valve has 3 leaflets: an anterior, a posterior leaflet, and a septal leaflet. The anterior leaflet is the longest and the most mobile. The septal, although it's not necessarily represented here, is the shortest and least mobile. There are chordae, just like on the mitral valve, that are attached to two papillary muscles that support the tricuspid valve. The annulus is, like the mitral valve, saddle shaped, so it's ellipsoid and it has a concavity to it, like a saddle. But because of some unique characteristics of the tricuspid valve, particularly because it's a fibrous attachment here, the tricuspid valve, when there's changes to the RV and annular dilatation, the tricuspid valve tends to dilate in an anterior direction, so it makes the tricuspid valve rounder and flatter as we have more pathologic changes to it. There are some important, in terms of potential transcutaneous therapies, I think there's some important landmarks to be aware of. Of course, everyone might remember the Koch's triangle here. The base of the Koch's triangle is the coronary sinus, something you want to be mindful of if there's any percutaneous treatments for the tricuspid valve. Of course, the AV node sits at the tip of that Koch's triangle. High incidence of AV nodal block, as you can imagine, if you do any percutaneous therapies. The non-coronary sinus of Valsalva sits right kind of behind the commissure of the septal and anterior leaflets. So if you're anchoring a valve into this area, then there's a high risk of aortic perforation, which is obviously a bad thing to do. And then the right coronary cusp fits sort of over here, the sinus of Valsalva, and that means the right coronary artery courses to the anterior part of the AV groove. And as it gets into the posterior segment, it can get very close to the annulus. Some reports say less than 3 millimeters away from the annulus as the right coronary artery courses through the posterior segment. So all important anatomical structures for us to be aware of. Clinical manifestations. There really are no symptoms associated with mild or moderate TR. This is why this is often an incidental finding on echocardiography. Severe TR, as it becomes progressive, can be associated, and is often associated with a pulsating sensation in the neck due to a distended and pulsatile jugular vein. And those can manifest also as physical findings on exam. Most commonly, we'll see that jugular vein become very distended and prominent, and also quite pulsatile, often confused with the carotid pulse, and that's, if we can all remember from our physiology, as the regurgitative jet fills up the right atrium, you'll see that transmitted into a large V wave in the right atrium, and that'll transmit into the jugular vein as a very prominent sort of giant V wave in the jugular veins. Progressive, it's important to remember that severe TR is a progressive disease and ultimately lead to right heart failure with hepatomegaly, with edema, with canvasarca, with ascites, and it can be very, very difficult to treat medically. The etiology of TR is generally in the literature broken into two main groups. There's, just like in the mitral disease, there's primary TR and there's secondary TR. Primary TR makes up, is caused by any primary problem with the valve. So think of congenital abnormalities or acquired, particularly iatrogenic abnormalities of the valve. Important cause in this group of primary TR would be injury from a biopsy, pacemaker and defibrillator leads. If they're increasing in incidence, would be considered a primary cause of TR, and that makes up the minority of causes of TR, less than 10%. The vast majority of cases that we see of TR are going to be secondary TR, and that's anything that results in annular dilatation. This is key phrases here: leaflet tethering and leading to malcoaptation, just like the mitral valve. Things that cause the heart to dilate, particularly things like pulmonary hypertension, left-sided valvular disease, myocardial disease, that puts increased stress on the right side of the heart, will cause that annular dilatation and ultimately that malcoaptation, with leading to TR. This makes up the vast majority of patients that we see with significant TR, about 80%. And as I mentioned, it's often caused by left-sided valvular disease. And as an example of that, in patients with severe MR or severe AS, at least moderate TR is present in 25 to 40% of those cases respectively. It's also important to remember that this often, in small studies, doesn't get better with MitraClip or with TAVR. And it's also appears to be a marker of mortality because of the TR. So something to keep in mind as we develop more percutaneous therapies. And then in some in some reports now, they're separating a sort of a new entity of TR that some call isolated, others call idiopathic. It's a minority of patients with TR, but there are some patients who do not have the characteristic presence of pulmonary hypertension or left-sided heart disease. This tends to be the older patients. There's a high frequency of AFib in these populations, yet they're not manifesting as this group above with pulmonary hypertension and heart failure per se. And it's felt that the mechanism for this is pronounced right atrial and tricuspid angiodilation, again, likely from the arrhythmia and the chronic changes in the heart. For those graphically minded people, here's a schematic showing the breakdown of primary and secondary TR. Remember, primary are things that are caused directly to the leaflet, so think of your congenital causes, infection like endocarditis, odd things like carcinoid radiation, and then finally, maybe an emerging important cause would be damage from things like biopsy and device movements. In the secondary group, there's a large group that are caused by secondary to pulmonary hypertension, so think of our heart failure or valvular heart disease patients. Some people can have just a myopathy affecting the RV, like think ARVD, and then less commonly, things that are called purely volume overload of the RV, like shunts or high output failure, can also result in significant TR. And then finally, there's that idiopathic group that is closely associated with AFib and the elderly population. So the best natural history information for TR comes from an older study done at the Palo Alto VA. They studied retrospectively a little over 5,000 mostly male veterans who were average age in the mid-60s. And they followed them for an average of about 4 years after they had an echocardiogram. As you would expect, the breakdown of how much TR they had at baseline was, as we often see in clinical practice, right? About 10% had no TR, the majority of patients had mild TR, and a smaller percentage, 12% had moderate TR, 4% or so had severe TR. And what was striking in this retrospective study is that TR is associated with very high rates of mortality. If you had no TR, your 1 year survival was 91%. If you had severe TR, your 1 year survival was 64%. Here's the Kaplan Meier curve for their long-term data, and you can see the patients with no or mild TR did much better than the patients with moderate or severe TR. What's also impressive is how early these curves separate. Patients do poorly quickly with severe TR, with moderate or severe TR. As I mentioned, TR was an independent predictor of mortality. And what's interesting is that I could show you this in the article. There is the same graph stratified by patients with pulmonary pressures greater than 40, pulmonary pressures less than 40, EF greater than 50, EF less than 50, and all the curves look identical to this overall survival curve. So it doesn't matter if you have pulmonary hypertension baseline. It doesn't matter if your EF was low or high. You had a poor prognosis if you had moderate to severe TR. And this is, so after this trial, there have been smaller publications in various clinical settings, patients with AFib, patients with severe MR, showing similar information that TR is a predictor of mortality. And here's just one example. It's a smaller trial. All the other trials have been smaller. But this is a trial of 240 patients who had a device implanted. So this would be a primary cause of TR. And what they did in this trial from the Netherlands is they retrospectively evaluated patients who had a baseline echo and then had an echo between 12 and 18 months after they had a pacemaker or a defibrillator implanted. And they found in that 240 patients that about 40% of them had significant lead-induced TR in that time frame after they had their lead implanted. And that was defined as TR increasing to at least 2+ on echocardiography. And as you can see, similar to the trial I just showed you, mortality is significantly worse if you have significant lead-induced TR. Perhaps not as great a separation as we saw in the earlier trial, but nevertheless a highly significant hazard ratio here in survival in patients who had lead-induced tricuspid regurgitation. So it's bad in any situation, right? TR is a bad player. As far as treatment, we target treatment to the underlying disease process. So we treat the pulmonary hypertension, we treat their CHF, we treat their AFib, we treat their left heart disease, we treat their mitral regurgitation. But we don't have really any great targeted therapies. Typically, we'll use diuretics for volume overload, but there's no data to say that that is altering their disease progression. Loop diuretics are what we typically use, but aldosterone antagonists I've read has been useful in situations where you have hepatic congestion and secondary hyperaldosteronism. Kind of makes sense. But as anyone who's taken care of patients with severe TR, these patients have really refractory edema that's really unresponsive to medical therapy. So typically in a situation where we have patients who are unresponsive to medical therapy, we turn to our surgical colleagues. And so in this case, like with our other valvular lesions, surgery is the definitive therapy for severe symptoms. The problem is there's a huge treatment gap, right? I told you earlier, 1.6 million patients have significant TR in the US. There's a whopping 8,000 patients who undergo a tricuspid valve surgery in the United States on an annual basis. And the vast majority of those patients are having it because they're having left-sided surgery. So 12% of patients at most in this country are having primary tricuspid valve surgery if they have severe TR. So that's pretty stunning how few patients are actually getting their tricuspid valve tricuspid regurgitation treated. Just an example from a surgical literature about some methods of repairing or replacing the valve. They call this the bicuspidization of the tricuspid valve, where they remove, it appears, the posterior leaflet. There's surgical, using stitches to do an angioplasty, and the traditional angioplasty, and of course there's just the valve replacement. But in the literature, 3/4 of all operations on the tricuspid valve are repair rather than a replacement. Even that data shows that the result is not very durable. So I'm a big fan of the ACC/HA guidelines, but they're really woefully inefficient or insufficient in this case. It does not do a lot to help us manage patients with severe TR because there isn't a lot of evidence. You can see that here, the level of evidence for all these, except one, is level of evidence C. So we're dealing with expert opinion here. There's very little evidence to guide us here. And there's really only one class 1 indication for surgery, and that's if you have severe TR at the time of left-sided surgery. Duh, right? We're going to do that. And then you'll see some 2A indications that largely have to do with kind of obvious situations, but they have no real evidence to support them. That may be appropriate if you're unresponsive to medical therapy. It may be appropriate at the time of left-sided if you have mild or moderate disease. And then there's a bunch of class 2B indications, which I'll remind you is like flipping a coin, right? Not a very strong recommendation to do any of these things, but it may be appropriate if you have mild or moderate TR and pulmonary hypertension. It may be appropriate if you've had previous left-sided valve surgery and you have severe symptomatic TR. Good luck finding a surgeon who will take that repeat surgery patient for severe TR. It may be appropriate if you're asymptomatic or minimally symptomatic, but you have severe TR with at least moderate RV dilation or dysfunction. So I just don't find in this situation the guidelines are very helpful. And a lot of that has to do with really the reluctance of surgeons to operate on this lesion. And I can't fault them for that because the mortality of that is terrible. It really is. Isolated tricuspid valve surgery has the highest surgical risk among all valve procedures, an operative mortality approaching 10%. 10%. Would we really feel comfortable referring our patients for surgery when their operative mortality risk is 10%? Would you be comfortable as a surgeon operating on someone if your operative mortality rate is 10%? I think that's too high. And the other reason that I think we're underutilizing surgery is that there's very little surgical outcome data, especially in patients with isolated TR in that setting of, without having left heart failure or a left-sided valvular lesion. As far as I know, there's only a single study comparing long-term survival, surgical versus medically managed patients, and there really wasn't a significant difference in in mortality in that surgical versus medical trial. There have been multiple small studies, we're talking 30, 40, 50 patients that have shown an improvement in symptoms, but there's no clear survival advantage to surgery in a single trial. Here's what one trial from Korea looks like, where they looked at patients, their functional class before and after surgery. There were 61 patients initially who were prospectively enrolled in this trial. Guess what the operative mortality rate was in this trial? 10%. 10%, right? So 6 did not survive the surgery. Of the 54 who survived, 61%, so a good number of patients, had improvement, mostly from functional class 3 to functional class 2. That seemed to be where the bulk of patients improved. So it can help with symptoms. Unfortunately, we just don't have long-term mortality data to support sending our patients. So because the guidelines are I think, a little lacking, this is the best algorithm I found, published by Rick and Mishimura in a review article, looking at how we should maybe manage our patients with severe TR. If you're asymptomatic, you should assess their right atrial pressure. If it's elevated and they have persistent AFib, then you should consider rhythm control. If they're not in AFib, then you should start diuretic therapy. Our symptomatic patients, if it's a primary valve lesion, and if it's due to a device, then